mentioned, I'm Jen Covich. Delighted we're going to have Rear Admiral Michael Todt speak today. He's from the Indian Health Services and the Chief Medical Officer. Very excited to have him here today. They're playing a really important role right now in a lot of this. We also have with us John Sun with Indian Health Service and Rural Health with Philips. And John's been doing work with Indian Health Service and is going to be talking a little bit about that and the role of data and telehealth, which is really important right now to that community and helping a lot. So delighted to have John with us here today as well. And we also have, we're really fortunate to have Colette Adamson, Dr. Adamson here with us today. Uh-oh, something happened with our slides there. And Colette's going to be talking about disparities in social determinants. Colette is actually with the Turtle Mountain Band of Chippewa Indians, the Center for Rural Health, the University of North Dakota School of Medicine and Health Sciences, and director of the National Resource Center on Native American Aging. So really excited to have her here with us today. A couple of housekeeping items. Sarah, if we could pull up the slides again, that would be great. Everybody is muted right now. If you would like to ask a question, please go ahead and raise your hand. Oh, keep going. One more, there you go. Raise your hand if you'd like to ask a question and we will unmute you so you can ask your question, or please go ahead and put your questions in the chat box there. There is a Q&A box. There is also a chat box there. We'd be happy to answer your questions. You can start putting them right now. If you have questions on the report, which is available on our website, ehidc.org, or on any of the presentations today, please feel free to put a question in there. And there's also a chat box there. If you have technical difficulties, please chat with Sarah, who's here, and we'd be happy to help you out. If we can go back one slide, I just would like to thank Philips. We are eHealth Initiative, a really small nonprofit, and we can't do any of this work that we do without the support of generous organizations, and really was delighted that Philips helped support the research and the report writing for this. So thank you to Philips for that. Keep going. So what I want to do now is just talk to you briefly about our work and tell you a little bit about the report. So for those of you who aren't familiar, eHealth Initiative is a nonprofit. We've been around for about 20 years, and we do research, education, advocacy around critical issues to support executives who are transforming healthcare. Next slide. The eHealth Initiative is made up of dozens and dozens of stakeholders across the spectrum of healthcare. And this is just a sampling of some of the leaders, Sarah, if you can show that leadership slide there, of the different organizations. We work with payers, providers, labs, pharmaceutical organizations, vendors, all different sorts of groups that contribute to the work that we do. Next slide. And the current focus areas, the critical focus areas that we're working on right now are consumer privacy, social determinants of health, telehealth, and the use of data and innovation to address COVID-19. And as you can imagine, that's a really important topic right now. This is an example of some of the recent forums and webinars our organization has held. You can see there's a number of different COVID programs, and these are all actually available online. So you're welcome to go download any of those that you would like. There's a number on telehealth and policy and a number on privacy as well, just to give you an idea of the different resources that are available for you. And finally, we do a number of research and reports and surveys, which you've probably seen out there in the field right now. This is just a sampling of some of them, but if you go to the next slide, drum roll, this is the brand new report we're talking about today. So this is the report which was developed after a meeting with a panel of experts that we convened back in August, a couple of months ago, from tribal communities, government, nonprofit, and universities. And originally we were trying to figure out how social determinants of health and those drivers, how that really impacted American Indian and Alaskan Native populations and what that was looking like with COVID-19. And that's how we kind of got started on this topic initially. And it really turned into just an incredibly meaningful and robust conversation. And I think what we wanted to do is really bring to you today a sampling of that conversation. And I would like to encourage all of you to download a copy of that from the EHI website. Next slide. And the report will highlight gaps, challenges, and some of the unique needs of these communities. It goes into detail about lack of infrastructure, some of the historical underfunding that's taken place, the difference between kind of the rural area issues and the urban area issues, and then some of the negative outcomes that are being caused by the poor data quality, which we'll talk about today. Next slide. And finally, there's a number of different recommendations there about how this can be addressed in the community. And some of the core recommendations dealt with increased staffing, providing cultural literacy training for professionals, respecting tribal sovereignty, and addressing behavioral health needs. And again, we'll touch on each of these today during the discussion. Next slide. I'm really delighted that we have with us today Rear Admiral Michael Todt, again, who's the CMO with Indian Health Services. Dr. Todt, I have to tell you, was just a tremendous participant when we had this session, and I think you'll be very impressed with the data that he has to show. I mean, I think he's really the data czar over there at Indian Health Service, and just really a wealth of information. We're so delighted that you took the time to join us today. So welcome.
Thank you, Jen, and thank you to John and to Colette for joining as well. I wanted to first just briefly say, since I heard Colette's from the Turtle Mountain Band of Chippewa, that my first rotation as a medical student with the Indian Health Service was in North Dakota. I know the land up there somewhat. So I do want to thank you for the opportunity for bringing this important group of stakeholders together and for the report that's been generated. And I'll provide you with some updates. So in the report, of course, it was through our interviews, and as we know, if you wait a minute, the news changes, and so I do have updated data that I will share with you today. Next slide, please. And the Indian Health Service, just for an overview, we provide comprehensive health delivery system for 2.6 million American Indians and Alaska Natives, and that's done in service of members of 574 federally recognized tribes across 37 states. Our fiscal year 2020 budget appropriation was about $6 billion, and then third-party revenue collections was approximately another $1 billion on top of that, for an overall budget of $7 billion. The IHS staff consists of more than 15,000 employees, including nurses, which are our largest category, and then physicians, pharmacists, sanitarians, physician assistants, and dentists. Next slide, please. That system is done through IHS Tribal and Urban Indian Organizations, so it's not all through federal facilities. As a matter of fact, more than 50% of our services are now delivered by tribes through self-determination through their own facilities, as well as through our urban Indian organizations. But American Indian and Alaska Native people have experienced lower health status compared with other Americans. And we know that in particular that diabetes is one of the medical conditions that's been associated with increased risk of complications in COVID-19. And American Indian, Alaska Native people have the highest prevalence of diabetes in any US racial or ethnic group. Other conditions that increase COVID-19 risk are also common in American Indian, Alaska Native people, and that includes obesity and diseases of the heart, lungs, and kidneys. So we know that our population is at overall higher risk for severe illness and have higher than comparison groups in terms of significant underlying medical conditions. Next slide, please. American Indian and Alaska Native people are more likely to live in crowded housing situations, and that increases the likelihood of spreading the coronavirus. Some may not have access to running water in some areas. We heard prominently on the news about water access issues in Navajo, but it's certainly issues in many of the places that we serve. We serve some of the most rural and remote places on the planet, actually. So we're unable to adhere to hand washing recommendations when individuals are living in an area that may not even have access to water. We have high rates of poverty, food insecurity, and American Indians, Alaska Natives are more likely to work in frontline jobs that are not necessarily eligible for telework accommodations or other social distancing accommodations. These social determinant issues make it more difficult for American Indian and Alaska Native people to avoid exposure to the coronavirus and also to avoid the serious complications if they contract it. Next slide. The IHS and tribes have been working to reduce the effects of chronic diseases and social determinants of health. Recent studies have shown a decrease in diabetes prevalence, and this is the first decrease in diabetes prevalence that's been documented in any ethnic group, and American Indian, Alaska Native people have been able, through self-governance and self-determination, to be partners with the Indian Health Service in reducing diabetes and diabetes complications, including kidney failure, eye disease, hospitalizations for uncontrolled diabetes, and mortality. And of course, there's still work to do, but I do want to recognize that significant progress. Many tribes are increasing their outreach services to communities during the pandemic, especially providing food, masks, or laptops for children who are distance learning. But again, broadband remains an issue, as we'll discuss later. The IHS has allocated more than $5 million for the Coronavirus Aid, Relief, and Economic Securities, or CARES Act, to increase water access on the Navajo Nation. And the IHS is seeking input from tribal and urban Indian organizations currently on a draft plan outlining how the IHS healthcare system will prepare for and operationalize distribution of a vaccine when it becomes available. Next slide, please. We do have a four-pronged strategy, and I will go over each one of these. Prevention is the first one, and then we'll later go into detection, treatment, and recovery. So starting with prevention, we want to make sure that everyone messages the 3 W's. This is something that all of you can take back to your communities. It's a good elevator speech. The 3 W's: wear a mask, wait 6 feet apart, and wash your hands. It's more than just an elevator speech, though, because it saves lives. And don't let the simplicity of it fool you. This is really the most effective method we have right now for controlling the coronavirus. So wear, wait, and wash. We have distributed more than 65 million units of personal protective equipment to IHS, tribal, and urban Indian organizations at no cost to them. We encourage all of our sites to provide training for that as well. So just having the equipment is not the same thing as putting it on properly. Donning and doffing personal protective equipment takes actual training, and then also quality assurance and performance improvement practices to monitor that. We have to make sure our staff have rest cycles. We have to communicate well with staff, community, and tribe. We're using ICAR, or the Infection Control Assessment and Response, which was developed by the CDC. And we're doing these through tele-remote sessions to really help to make sure that we're optimizing the use and the strategies for infection control. The Navajo Area Clean Water Access Project, as I mentioned earlier, is being done as a partnership with Navajo Nation and the IHS Office of Engineering and Environmental Health. This is, again, so important to make sure that we're addressing the social determinants of health that directly affect not only the transmissibility of the disease, but also the preponderance to be at higher risk for worse outcomes. In terms of vaccine strategies, we've been focusing on youth vaccination, catch-up strategies in terms of any vaccines that might have been missed early during the pandemic, when individuals were more likely to stay home or only use telehealth. They may be behind on vaccines, and so we want to update that, addressing any preventable illness, especially flu season. And so as we started flu season, we're focusing certainly on our seniors, but really the entire population. Anybody 6 months or older without a contraindication should get a flu vaccine. And then we're working on tribal consultation, the voice of our tribal partners, as well as our urban Indian organizations through the confer process. It's so important that we consult with tribes on the vaccine distribution plan for COVID-19. Next slide, please. In terms of detection, we are screening before each shift for healthcare providers. We are using testing different types that are available. We're using the state public health labs, but also using commercial send-out labs. We're using point-of-care tests, such as the Abbott ID Now and the Abbott Binax Now, and we receive distributions through HHS for each of those. We do have a high-level goal, and that is to exceed the per capita testing by the user population compared with the US all races, and to maintain a positivity of less than 10%. Of course, within each community, that's tailored by that community, but we suggest a local floor testing goal of at least 2% of the population per month, but then also targeted surveillance for the highest risk: elders, those with chronic disease, those who work in commercial food production, such as canneries, and then increasing testing if necessary until the 7-day positivity falls below 10%. Next slide. I'll show you some of the results that we've had with our testing. We've tested, as of October 7th, we had tested 933,192 individuals, and of those, 55,326 were positive, with the preponderance of those tests coming back negative. Our cumulative percent positive, if we look across the entire pandemic and across all of the IHS tribes and urban Indian organizations, we're at 6.3%. And then we have in the far right column a 7-day rolling average where we're at 4.9%. You'll note that there's marked variability across the areas, and also we have differences between that cumulative percent and 7-day that I'll explain in some further slides. Previously, Navajo had the highest number of positive tests. More recently, Oklahoma City area has now passed the Navajo area. Of course, they do have a higher baseline denominator, so their population is higher in the Oklahoma City area, but they have now passed Navajo area in terms of raw number of test positives. Next slide, please. The importance here is not to underestimate the impact of the pandemic in every single community, and really no community was left unaffected. And the smaller dots do represent smaller outbreaks, smaller numbers of positive, but really no size of the dot can tell you the size of the impact on the community. Some of our Alaska Native villages are very small, but even a few cases in a village can essentially devastate that village. And so again, the point of this slide was just to show that we've really had impact in all of our areas. And again, the raw numbers don't adequately represent the impact on the community. Next slide, please. In terms of per capita testing, so we look at the numbers of tests per 100 population, and as of October 7th, we were at 56, a number equivalent to 56% of our population. And I say a number equivalent rather than actual, and that's because obviously you may have some individuals that required retesting. This may involve some of our workforce being tested as well. However, the comparison, which is the blue line, the US all races, has the same caveats, and the US all races testing rate is a number equivalent to 37% of the US population. So we are testing at a higher rate. We should be testing at a higher rate because we're at higher risk. There's a higher prevalence, but that's a goal of ours to do that. Currently, all areas are exceeding that US all races with the exception of California area, Portland area, and Tucson area. So we're achieving that in 9 areas. We're below that in 3 areas, and the overall testing rate is much higher. Next slide, please. So all these tests come back, we get the results, and that gives us our positivity. We take the positives divided by the positives plus the negatives, so we're not counting those that are pending, and that gives us our positivity rate. Our positivity rate does vary in the different areas, but also when we look at the orange bar, which is the US all races, we're at 7.6% as of October 7th. and the US all races was at 6.3%. So the positivity, excuse me, I said that backwards. The US all races at 7.6 and the all IHS at 6.3. So the all IHS positivity rate is lower than the US all races. However, this does vary significantly area to area. For example, the Navajo area still is coming down. They have a much lower 7-day positivity rate, only of 1.4%. But when you look at their cumulative, because they had so many positive, they're still at 13.5 and falling. Phoenix area is also at 13.8% and falling. But you'll see that marked variation. Alaska area, which had so few positives in the beginning of the pandemic, is still at a cumulative testing positivity of 1.3%. But their tests have shown more positives recently, and they're on the increase. So again, marked variability, but overall, our testing rate was lower nationally. Next slide. When we do break it down by area, the brown slope that represents the Navajo area cumulative positives, you can see that Navajo area and the Navajo Nation, they were successful at flattening the curve. That number, that slide will always show a curve that maybe goes up or flattens. It can't come back down because it's cumulative. So the best you can do is flatten, and you can see that Navajo was able to flatten the curve. Similarly, the next one over is the Phoenix area. So kind of that light brown. Phoenix area also had a rapid rate of increase and was able to flatten the curve. I'm very concerned about the Oklahoma City area right now. And as you know, the state of Oklahoma is also one of those states that's having an outbreak. And so we would like to see them flatten the curve. Great Plains area, similarly the Alaska area, Billings area, all have rates of increase that are concerning. And we want to make sure that those curves go back to flattening out again. Next slide, please. Our daily and cumulative for all IHS, and we can break this down further by area, but just for purposes of today's discussion, that cumulative number positive has, again, that unacceptable rise. And if you look in the middle section, so in July, most of that in May through July was driven by the increases in the Navajo area and then the increases in the Phoenix area, and they came back down. But unfortunately in September, now moving into October, that's where we're seeing the effects of the increases in the Great Plains area, in the Oklahoma City area, in the Billings area, and in the Bemidji area. So the Midwestern states and the center of the US are seeing the marked increases that previously were seen in Navajo and Phoenix area. Next slide, please. Again, more relevant than the cumulative positive is going to be that 7-day average. And the 7-day average was at 4.9%, which is comparable to the US all races. So again, my concern is not so much that overall number because it's relatively flat, but when you break it down by individual area, that's where the concerns really show themselves, especially with those areas that are having higher increases. Next slide, please. So that's the data section in terms of the detection for COVID-19. And in terms of treatment, we have worked to really buckle down and restart, reboot, reinvent how we provide access to care. And that means expanded telehealth. So it's extremely important that we continue to provide the well care, to do the cancer screenings, to do all of the attention that's necessary for behavioral health, for mental health, for substance abuse disorder, and really all of the chronic disease management as well. So telehealth doesn't solve everything, but it's an important part of our strategy, and we've increased our telehealth manyfold, and really see this as a continued reliance, especially in rural areas. It brings that specialty expertise also into remote rural areas that don't have that access. We're monitoring our staffing, our hospital capacity, We're partnering with the VA for overflow situations. Lots of the care that's being provided all across the US in terms of critical care, delivering antiviral therapy, immune-based products, adjunctive therapy. All of that has to be delivered in a culturally competent, relationship-based manner. We have to make sure that our care is delivered in a manner that's respectful and appropriate and going to be well received by the population that we serve. We are monitoring the COVID-19 treatment guidelines, updated regularly by NIH, so that link is really important, the What's New site on NIH. Also maintaining readiness and trainings on emerging treatment, but then standardizing all of this with quality assurance, performance improvement, making sure our pharmacy and therapeutics committees are involved, the medical staff, governance, they all need to keep up on these new treatments as well. Next slide, please. And then our fourth strategy is recovery. And we will get through this. This has been absolutely traumatic and really challenging for all of us, but I think the message has to be one of positivity that we will recover. We have to ensure safe resumption of all of our core services with a special focus on well child care, immunizations, and prevention. We have to be mindful of the trauma, the shared trauma that this is impacting upon all of us, and we have to watch for and prevent the effects of historical trauma with this horrible pandemic in Indian country. We know it's affecting all people, but it's disproportionately affecting American Indians and Alaska Natives. So we're monitoring our performance measures, not only with COVID-19, but also with chronic disease management and prevention, immunizations, looking at our workload and our quality and our access indicators, really working to maintain staff and community resilience. American Indians and Alaska Natives have survived through many different challenges, and they will prevail over this as well. And so we have to draw on that resilience that can really take us forward. You can always go to ihs.gov/coronavirus, and there's additional resources under a tab there as well for COVID-19 and emotional well-being. We encourage all of our staff to use the Employee Assistance Program and Core Cares. But those resources are also available to the public. So if you want to look at those resources and those tools that are there, please do that. Next slide, please. So that concludes the IHS presentation. Of course, I will stay on for questions when it's time for that. So thank you.
Great. Thank you so much, Dr. Toad. And I know we've already got a number of questions coming in here. So keep your questions coming and we will get to them at the end. All right, now we're going to turn it over to John Sun. John.
Wow, that was a great presentation, Rear Admiral Toad. So how do you follow that? I'll do the best I can. So my topic is specifically on the role of data in telehealth to address population health, specifically during the pandemic era that we are living in. Three of the topics that I'll be talking to is what is the importance of telehealth and virtual care to stopping the pandemic? What are telehealth challenges that create barriers to care? And then what are the, how can data help and gather and to be analyzed to make better decisions? So what I want to show first is that the kind of step at a very high level that I want to illustrate that healthcare today, and more so than ever, that the healthcare delivery is an ecosystem, and that ecosystem is aligned to the specific population it serves. The ecosystem must also be driven by a platform. So what you see there in the graphic is that in the cloud is a ambulatory or acute to ambulatory and then to personal health, basically with patient engagement and relationship in the middle, but is also being driven, and the engine that is being driven is a platform. And why is that important? Well, the ecosystem basically, it recognizes that solution must address a level of complexity and variability of the ecosystem, and be ready to, dynamically enter one journey from another, trigger the next steps, and deploy sustainable, personalized solutions. Because you walk into a hospital, there is a waiting room or a check-in. While in virtual, you could enter at any time. Telehealth platforms with its innovative solutions and technologies have far outpaced adoption of the telehealth. And I'll talk a little bit about some of the barriers and challenges in a later slide. But you know, a healthcare ecosystem that could dynamically respond to patients or consumers and healthcare needs, no matter where, when, how they enter the system, as there is no definitive entry point or digital front door. And the new solutions such as Indian Health is addressing, such as Rear Admiral Toad has stated, is that it must address all the complexity and be ready to be, you know, dynamically meet the patient and the consumer where they are. Next slide, please. So basically from the overall high level, kind of drill down to the acute to ambulatory, what I wanted to kind of illustrate is that, you know, the first bullet is, the question was, how can telehealth stop the pandemic? It can't, but it could certainly help with the limit of the spread for obvious reasons. But, you know, you could also introduce contact tracing, and when you're at an alternative site hospital, it could also address some initial diagnostics before one even enters an alternative site hospital with some solutions. And then basically another way to do it is through, you know, we heard about remote patient monitoring. You know, what does that really mean, or what does that take? If you have mild symptoms, even symptoms that may not be 100% aligned with COVID, but if you deteriorate, and it could be, get worse, it could get worse, you know, remote patient monitor is a way to kind of send the patient home, monitor them from a remote area, and before it gets worse, or if it does get worse, have them come back to the care location of choice. Also, how does it help? Telehealth, basically, it shares data in real time. And for obvious reason, telehealth, especially in the Indian health context, it will save travel time and thus save money down the road as well. The staffing shortage that we've found that was consistent throughout the local government and state local government is something that I think a lot of the decision makers weren't really prepared for. But I think through telehealth is a way to kind of mitigate some of that staffing shortage, especially introducing some of the telehealth solutions. Next slide, please. So the typical barriers of telehealth kind of remains the same. I'm not going to go through all these bullets. Some of them is kind of self-explanatory. But, you know, although some of the telehealth programs was forced to propel during the COVID pandemic, execution of the telehealth program remained very complex and has many, many challenges. You know, some of the topics that Rear Admiral Toad and Deweki is thinking about is, you know, is the adopted platform, is it siloed, and how does it solve interoperability issues? How does it even advertise or market the telehealth program to the public, in addition to training the public how to even schedule an appointment? How does a provider split their caregiving time from in-person to virtual? How does a C-suite or decision makers within each local area down to the hospital or the tribe, how do they make a decision in regards to demand and staffing? And which specialty gets priority? Those are some of the decisions that the decision makers must make during these trying times. How to retrieve vitals and data such as patient records, electronic health records. Acceptance. We all know that due to population, some of the acceptance, especially with the older generation, there's still that lack of accepting telehealth, kind of like how I'm kind of aging myself here, but it's kind of when they introduced ATMs, you know, that was not widely accepted when it first came out, but now we're taking pictures of a check and saving it. So, so the acceptance needs to get there, needs to catch up, and then the ever so issue of infrastructure, especially with rural areas, And the last thing is how do you even get a technology or telehealth technology once a hospital is adopting a telehealth operation? So those are some of the key barriers of telehealth. It continues, although some of the barriers has been propelled because of the pandemic, such as President Trump signing some of the laws, relaxing some of the HIPAA requirements and things like that. But moving forward, it really needs to mature. It really needs to meet the demand of during a pandemic situation. So it will continuously need to be improved. So I want to go back, go to the next slide. Is the last topic is basically data. How can data help during a pandemic? While we talked about remote patient monitoring, and what I'm showing here is a Philips solution, but any wearable could help deliver vital data to clinicians. This one specifically has a 30-day battery charge. And even with a slight symptom, like I said before, like a fever, a cough, we could put this sticker on and monitor a person without having that same person affecting the entire hospital or a department. So once that data is collected, it will send that data, every hour to the right clinician, and he or she will look at it and analyze the data to see if it's getting worse, is it getting better, does he or she have to come in? And the next slide, if you will, go to it, it illustrates how that looks. So all the vitals are taken through a report from, like I said, temperature and coughing, what type of cough, the frequency of cough. But then if you see that big graphic to the right, there's a spike in temperature in that short amount of time. And that is a trigger for the clinician to say, okay, here's an alert, please come in, and we'll take care of you at the actual hospital. So that's one way of data helping. But I want to go back now. We kind of went from the ecosystem down to the individual solution. If you go to the next slide, I want to go back to that ecosystem now. So this is how we are helping on a national level. So this is basically a emergency preparedness through a command center. So, we talked about how the data from the ambulatory or the home health could be monitored via command center to guide decisions, especially from a pandemic or emergency preparedness point of view. This is it. In the far left is a platform, and then to the far right is a command center, and then in the middle is basically all the participating affiliates that we have programs at. And this is something that I really think is very strong during a pandemic situation, through telehealth, through using all the individual solutions when it comes down to either the acute or to the ambulatory, but it's monitored through a command center. So now is going back up to the high level of how telehealth could support Indian health. And then we talked about data, how it supports telehealth in a pandemic. I want to talk about how data could help outside of a clinical setting. So if you go to the next slide, this is something that we're also proud of, is all these alternative site hospitals was being kind of initiated by the local government. We took data and we supported the DC Search Center through just kind of like, hey, how do we look at the 7 existing hospitals in Washington, DC, knowing that the DC Convention Center was the alternative site hospital, and the measure of performance is, if we don't allow a single COVID patient inside the DC Convention Center, it's a success. And that's exactly what we did. We looked at the existing 7 facilities. We looked at how we could best maximize the utilization of the 7 hospitals. How do we maximize the utilization of the staffing? And that's what we did. So this is another way of thinking data and how data could help during COVID. And I just want to kind of go to the next slide and just end with, telehealth is a disrupting care delivery solution. Whoever decides telehealth in their program, they have to understand it from think about it from a forward-thinking point of view. What I mean by that is, we always, the C-level, the C-suite level, and the leadership level is always looking at the quadruple aim, which is, better outcomes, better experiences for clinicians and patients, better operations, and lower costs. But whatever the platform, the telehealth and healthcare in general must be visualized as a continuum, since it suggests that, the notion of continuous care and recognizes that health begins with the consumer and goes beyond the interactions that occur within the clinical setting. And we at Philips sees an opportunity to transform the delivery of the care by connecting people, data, devices, technology across the entire continuum with our combined offerings and technologies. And telehealth is just one way, but whatever telehealth solution one adopts, it must have the flexibility, and the adaptability, the scalability and sustainability for their mission. To do this, we're developing integrated solutions that improve financial, operational, and clinical outcomes at lower cost, scalable, configurable solutions based upon common design language and harmonized solutions and softwares. And telehealth is here to stay. It's getting mature, but I think whoever is deciding on that program, I truly think that they have to think about, is it flexible enough, is it adaptable, is it scalable, and is it sustainable? So I'm going to end my presentation there, and I'd be happy to answer some questions later.
Okay, we'll go to questions. Let's hear from Dr. Colette, Dr. Adamson. Oh, I think you're on mute, Colette. So Dr. Adamson, sorry.
I apologize, sorry. Good afternoon, everybody. I'm so happy to be here. And those are two amazing presentations with a lot of great information. I really enjoyed them. Like Jen said, my name is Colette Adamson, and I'm the director of the National Resource Center on Native American Aging. And what our resource center has done, we're a 26-year resource center. We work with tribal Title VI programs, aging programs, senior service programs in the communities to conduct a self-report health and social needs assessment with the elders to identify priority needs within the community for our elders. And then we work in partnership with those programs to try to come up with community-based solutions to address those needs. So I've seen a lot of the needs with our elders throughout the communities and throughout our country. And I'm also an enrolled member of the Turtle Mountain Band of Chippewa Indians, as mentioned. I grew up on the reservation, and growing up on the reservation, I also witnessed a lot of health and social economic disparities within my own tribal community. So I've seen firsthand the effects of these disparities in tribal communities. Next slide, please. So here's a map. I just wanted to give you an idea of where my tribe is located. We're in North Dakota, and we're at the north central part of the state, and we're probably one of the smallest land-based reservations in the country, being 6 miles by 12 miles for our reservation. We have about 35,000 members that live on and off the reservation. And within North Dakota, you see that we have other tribal communities, Spirit Lake Tribe, Standing Rock, MHA Nation, or Fort Berthold, Sisseton, Wahpeton, Oyate Tribe, and it's not pictured here, but Trenton Indian Service Agency. So the other reason I wanted to show you a picture of this map is because right now, as you might have seen on the national news, the state of North Dakota is experiencing some of the worst outbreaks of COVID right now and high case percentages. And within our tribal community, we're doing okay. We have about 36 active cases right now, but our community, just like a lot of tribal communities throughout the country, are taking initiative where they're mandating masks. We have restrictions for businesses in terms of capacity. And then also one thing our tribe is doing is they're offering weekly testing to identify and isolate COVID cases that are happening within our communities. Just last week, we actually had a door-to-door testing that was made possible by our Turtle Mountain Vanachua Indian testing team for COVID. So they've been really trying to come up with, you know, innovative strategies to really try to combat this virus and to make sure that we slow the spread in our communities. You know, because if there were an outbreak within our tribal community, just like any other tribal community within the nation, it could be detrimental because, one, we don't have great healthcare access or resources at times, and we're located in a rural, isolated area, you know, with the next largest town or metropolitan area about an hour and a half away from our community. Devils Lake, Minot, Grand Forks is about 2.5 hours. Our state capital is about 3.5 hours. So the distance is very long to accessing healthcare if our IHS facilities become overwhelmed. So we see that all these issues within our tribal communities become exacerbated because of this virus that we're dealing with today with the COVID-19 pandemic. Next slide. So this kind of segues into the key topics of our discussion today. So health and social economic disparities have long plagued our communities and our American Indian, Alaska Native populations. And, you know, our people and our populations have experienced historical traumas such as colonization, exposure to foreign disease, such as smallpox, which was devastating for our populations, tuberculosis, measles, being put on reservations, children being taken and put in boarding schools where at times they didn't see their families for years, the termination era where some of the tribes are losing tribal recognition, relocation programs, and the loss of our culture and land. So this definitely had an impact on Native people and has led to, as mentioned earlier, the high rates of diabetes, obesity, hypertension, arthritis, heart disease, asthma, suicide, and depression, just to name a few. And as mentioned earlier, diabetes is, you know, one of the worst health conditions for Native populations, with 2.5 times the rate of diabetes compared to non-Hispanic whites. Some of the Southwest tribes actually experience, you know, rates of 75% with diabetes. So it's a high prevalence in those areas. And a lot of these chronic conditions can lead to the adverse outcomes if COVID is contracted within our Native populations. Other issues in disparities that we have are social and economic disparities, where some of our unemployment rates are 50% or more within our tribal communities, low rates of education compared to our non-Hispanic white counterparts, high poverty rates within our communities, overcrowding of homes, which was mentioned, multi-generational homes. So we have, you know, from young to our elders living in one home. So if one person contracts the virus, it's really hard for the rest of the family to social distance inside of that home. So there's a risk of, you know, the elder in the home contracting the virus, or somebody with an underlying health condition who's living in the home, and that could lead to some very negative outcomes if they were to contract COVID from that family member. As mentioned, there's lack of running water in some communities, which, statistics have shown us in the past lead to poor health outcomes. So that's another challenge. Living in food deserts, food insecurity is high. I know, like, growing up in my tribal community, we didn't have large supermarkets or access to healthy food options. A lot of times it was 30 miles away or an hour away from our community. So a lot of the times we had to travel out to get the healthy foods that we needed, or even just basic needs resources in general. So with the COVID-19 pandemic happening, this just leads to even more challenges because, whenever our people have to travel outside of the reservation, if state mandates or federal mandates don't align with tribal mandates, such as the mask mandating, all of the protocols put in place to keep Native populations safe, if they have to travel off the reservation, then they're putting themselves at risk, because they need those resources and they need to get supplies, food supplies, and different everyday supplies for their homes. So this could lead to some challenges and putting themselves at risk for contracting this virus. Another issue that has long been a challenge within our tribal communities is quality healthcare access. Just like all of our tribes are diverse, our Indian health service facilities and clinics are diverse in the services that they provide. Some just have clinical services, others have primary care services, some just have emergency services. Some of our communities don't have inpatient services. So if there were to be an outbreak in our community, our facilities could be overwhelmed pretty quickly, especially since, in the past we've dealt with and still deal with the funding and the under-resourced facilities, along with shortage of healthcare professionals within our IHS facilities. So with COVID occurring, this could just make these situations worse. And not to mention some of these patients that would have to be sent out to non-IHS facilities, they're dealing with being far away from their homes. Sometimes their families aren't able to travel to see them in the hospitals. And I know right now it's limited with COVID. So, they'd be far away from their families. The facilities off of the reservation might not have the cultural competence to treat the patient in a culturally appropriate way. So those are just some of the challenges. And then also looking at our high unemployment rates, that also leads to a lack of private health insurance. We have high rates of not having private health insurance. So if we have to go off the reservation for healthcare services, we have to rely on IHS as a third-party payer for those services. So that's another challenge within our communities in terms of, accessing healthcare, before the pandemic, and now even during the pandemic is making it even more of a challenge. Next slide. So now I just want to talk a little bit about the importance of data. So I think during the pandemic, we've seen, and this has been brought to the forefront even more, that it's really important that tribes and Native populations have comprehensive data. It's vital in being able to show your needs and not being overlooked, because a lot of populations that don't have data are often overlooked when it comes to resource allocation or funding efforts by our government and Congress. So in the past, we've really struggled with getting comprehensive data for our Native populations. We also need to have disaggregated data. So a lot of times national data sets put us as American Indian, Alaskan Natives, and then sometimes when it's small sample sizes, they don't have enough to draw meaningful conclusions or useful data, so they'll lump us in, with others. So it makes it nearly impossible for us to even see what's going on with our Native population as a whole. But even to disaggregate it, I think we need to be able to disaggregate the data even down to tribal level, because all of our tribes are diverse. We have unique needs, we have unique challenges. So to be able to disaggregate some of that data that's being collected, I think would be a real game changer for tribal communities. And that's something that needs to be looked at doing with our national and federal data sets. But just recently, the Tribal Health Data Improvement Act was passed by the House and will be up in the Senate. And what this does is it'll allow tribal and urban epidemiology centers to access those federal data sets. So they'll be more or less treated like state health departments, so they'll be able to access that data, because right now they're not able to access the data that federal departments collect on the American Indian Alaskan Native population. So if this passes through the House, this could definitely be a game changer for the tribes and the tribal and urban epidemiologies that serve tribes and urban Indians, because it'll be able to provide additional data, accurate data, that will help influence policy decisions to improve the lives of Native populations. In addition to this, our tribes and our tribal and urban epidemiology centers will have a say in how to better collect data for our tribal communities and our urban Indian populations. Next slide, please. So last thing I wanted to finish off with is talking about the clinical and vaccine trials. I know right now there is a push to recruit populations that have been underserved or are being impacted by this virus, or have traditionally been impacted by certain health issues more so than their counterparts. But within our tribal communities, the consensus in Indian country, for the most part, has been the lack of trust. And this is due to some of the research trauma that has occurred in the past, just the history of Native people being used as test subjects, and research being conducted without consent. Some examples include blood samples being collected that were used for other reasons other than what they were supposed to be used for. Sterilization being done in some of the IHS facilities in the 70s. So there has been some research abuse that has happened within our tribal communities. So right now the trust just isn't there. I'll give you a quick example. Our state in North Dakota, the governor announced that the state had been chosen for vaccine trials, and it had been mentioned as one of the reasons was because North Dakota had a high population of tribes and good relationships with tribes, but they hadn't consulted with the tribes or let them know what was going on. So there was a misunderstanding of what this actually was, and it ended up being a vaccine trial distribution. Where they wanted to invite the tribes to have a seat at the table, but because they didn't consult with the tribes and there wasn't communication, it led to a lot of mistrust, especially with some of the tribal members in North Dakota, because they did not want to be used as test subjects for a vaccine. So it's really important that going forward with these phase 3 testing trials, if they do want Native populations involved in them, that they have to consult with the tribe, not only tribal leadership, but I think also community members. They need to have transparency and answer any questions that the tribal members might have, the risks, the benefits, what can happen, what potential outcomes could be. So they know from start to finish what's going on, and to not pressure the tribal members or make them feel obligated to participate in these trials. Make sure that legitimate consent, there's a good consent process that's put in place. And finally, just to have the tribe drive some of this research in the trials and be included in the everyday decisions of what's going to be happening with them. I think it will be challenging to gain the trust of tribal members to participate in these vaccination trials, but these are just some suggestions that might be helpful, even having like an elder board to provide their feedback and suggestions on how this should be done in the community. Next slide. And that wraps up my presentation. Here's our staff at the NRCNAA. Next slide. And here's our contact information. If you have any questions or need to contact us for anything, please feel free to do that. And thank you so much. And I hope you have a great afternoon.
Great. Thank you so much, Colette. I really appreciate it. Okay, so I know we're running late, guys, and it's 3 o'clock, but there are a lot of questions. So I'm hoping our speakers can stay on for a few moments so we could just run through a few, if that's okay for folks. Dr. Adamson, Dr. Tout, do you have time? John?
Just a little, yes.
Okay, all right, we'll just go quickly. And I really appreciate Dr. Tote was actually answering a lot of questions here in the Q&A. So we'll actually send those out for those of you who can't stay on so everybody can see a copy of those up there. And I know, John, you've got some people who are interested in this as well. So it looks like you're gonna follow up with them as well. But one of the things I think, Dr. Tote, would be great if you could just explain about, because there were several questions about, first of all, a little bit about IHS and what exactly that includes. If you could just I know not everybody is well-versed in everything. So if you could just, for folks on the line that don't know what that includes.
Happy to do that. So the Indian Health Service consists of federal, tribal, and urban Indian organization partners. So our federal sites, these are hospitals. If you've seen a VA hospital in the same way, this is a federal hospital with federal workers providing direct health care. That used to be the majority. It's now actually in the minority. Tribes have taken most of the facilities through self-determination, and that's through Public Law 93-638. Those facilities then are tribally run. They may still have federal employees because tribes can still take advantage of that opportunity should they choose to do so, but they're actually run and managed and operated then by tribes. So we say the IHS and the tribal, and when I say all IHS, I mean the IHS and the tribal. And then I don't want to leave out our urban Indian organizations who provide care in many cities where there's American Indians and Alaska Natives of many nations and many tribes who may be living in an urban area, and they're able to access care through those organizations as well. So when I said all IHS in that data, I was referring to the federal, the tribal, and the urban Indian organizations that have reported. So it's 100% of the federal data and then a majority of the tribal and urban Indian organizations, that they've been great partners in this response.
Great. And Dr. Adamson, Dr. Toad, if you could talk a little bit about what are some of the differences between the rural and the urban that you've seen in terms of COVID-19, and are there different strategies that are needed? Colette, Dr. Toad, go ahead.
Yeah, I'll start with a few anecdotes, but would love to hear Dr. Adamson's remarks on it as well. I know, for example, when New York City was hit and in the throes of the worst situation at the time, we had very little data on American Indians and Alaska Natives, and obviously we know that they were in crisis mode, and they weren't collecting that ethnicity data that was so necessary. And so certainly no criticism of their situation and the response, but in terms of national data infrastructure and the need to have that that level of granularity to the data, that can't be underestimated. So that's one example in urban areas where we really suspect highly that American Indians and Alaska Natives are disproportionately affected, but we just don't have good data on urban Indians. and then in terms of rural places, we tend to have data from our federal facilities, and again, most of our tribal facilities are sharing that. Dr. Adamson mentioned the importance of it being a two-way street and of tribes having access to that data as well. There's a couple of things that we're doing on that front. One is that the tribal epicenters, which the IHS recognizes as public health authorities, they are able to enter into data sharing agreements and to get that level of data. So we have areas that have engaged in that and are able to work with and are analyzing and using that data. So through having a recognition of their public health authority as determined in the Indian Self-Determination Education and Assistance Act, as well as the Affordable Care Act, those had provisions that recognize and emphasize the public health authority of the tribal epicenters. And then tribes themselves also can exercise their public health authority and also enter into data sharing agreements. It's a little bit trickier when it comes to tribal level data at a facility that has members of other tribes. And then, of course, we are subject to the requirements of HIPAA as a healthcare entity as well. And so there's the difference between sharing data for public health authority and public health reasons versus issues around research and data access. And of course, we fully respect tribal sovereignty, but sovereignty from data can be looked at from so many different sides. And one of the sides we have to look at is the individual patient's sovereignty for their data and whether or not they choose to share it with their tribe. So that becomes a whole nother challenge for us. We're always erring on the side of patient protection, but really fully recognize and appreciate we have to be good partners with tribes and tribal epicenters to be able to combat the pandemic and to move forward in the future. I'd love to hear your thoughts, Dr. Adamson.
No, I agree with a lot of what you've mentioned. I think, in terms of, I haven't had the opportunity to work a ton with urban centers, but in the next couple months, that's going to be changing because we have an urban project to do a self-report needs assessment, and we're just in the beginning stages. But I think what's really hard is I don't think at this point in time we can measure the true impact on our urban Native populations because we're so spread out, so it's hard to collect that accurate data. I think urban populations tend to, suffer from some of the same disparities and challenges that tribal populations do. And sometimes, they don't have the support of the community because they are located far away. They don't have access to IHS facilities because they're not in the service area. So they do have some of their own unique challenges as well. So, we definitely need to find a way to be able to collect more accurate data for our urban populations. Just a comparison, I've talked to some of the urban centers and they're trying to still provide services to some of their urban elders within their community areas. Tribal elder centers are doing the same. They just tried to, come up with different innovative strategies to maintain those services. But yeah, I think in the end, data is challenging for both urban populations, I think a little bit more so than tribal populations, but tribal populations also have that challenge with data. And when you don't have the accurate data, you can't truly measure the impact of what's going on in communities and be able to find vital solutions for those issues. So I think though that we're on the right path going forward to kind of rectify some of this. So I think it's just going to get better, in terms of being able to collect that data for tribes and urban centers.
Great, thank you. And I appreciate everybody staying on this extra 10 minutes. I wish we had more time. And but I do want to commit, we will send out a copy of all the questions and answers that are up here, and a copy of the slides and the report are available on the website ehidc.org. And I want to again thank